Cabo course update, January 11th through 13th on the beach, all-inclusive, amazing, family-friendly resort. The ultrasound spots are almost gone. We still have at least a month or so worth of resuscitation spots left, and the teaching course, which is happening the 2 days prior, is still good for now. Plenty of spots if you want to join. So book your spot, get your room, and start dreaming about the sand between your toes. CaboFest2017.com. If you're not good enough at ultrasound, that's not an excuse to punish your patients with radiation. One other thing, for those of you who already registered for Cabo Fest and whoever gets the last few spots, we actually just extended the course by 2 days to allow more hands-on scanning and possibly so you can have a longer tax-free vacation. How much extra are the extra 2 days? Wait for it. $0. That's right. Some of the people already registered suggested it, and we thought it was a pretty incredible idea. Those last couple of days, we're going to do stuff like scan with experts for a couple hours, or be in class, Kahoots quiz, test your ultrasound knowledge, Pilates question and answer panel. Some pretty fun stuff those last couple of days. So register for the whole thing, and you get 7 days of education in Cabo, Mexico.
Get out there, ultrasound some hearts, some lungs, some IVCs. Let us know how you feel about it.
Yeah, we can definitely do that. Or we could be better clinicians and use our ultrasound.
All right, so that was a theory. Now let's talk about how to actually do it. We're going to go back and talk about pleural effusion first. So the probe you're going to want to use is either the curvilinear or the phase array transducer. The curvilinear is probably going to be a little bit better. It's going to give you a prettier looking image because it's going to be higher frequency, which gives you a better image. The phase array transducer works well. The phase array transducer has the advantage of being able to fit in between the ribs a little bit easier, so you're going to get less rib shadow, but the image itself is going to look as good. Now, as far as where to place this, you want to place it in the more dependent portion of the thorax with the probe marker facing up towards the patient's head. If you have them sitting up, you're going to be a little more accurate, but it's definitely not necessary. Now, there are two signs that we know of that can help us evaluate for the presence or absence of a pleural effusion, and that is the mirror sign and the spine sign. So this is the image that you're going to see here.
This is a fast exam view. Why are you showing me a fast exam view?
Well, it's really similar to a fast exam view, but we're going to go up a rib space. And instead of concentrating, if you're on the right side, you want to concentrate down here, the inferior pole of the kidney, called to the liver, kind of in the gutter area. Here, you're going to want to go up a rib space and really want to focus in on this white line right here, which is the diaphragm. We're going to talk about the mirror sign first. So remember, you have your probe up here. It's in the mid-axillary line with the probe marker facing up towards the patient's head, and you're going to get an image that looks like this. Now, remember, we talked about it earlier. The ultrasound machine and the computer attached to the ultrasound machine is not very smart. There are two things that it assumes are always constant. The first one is that sound is always going to move at the same speed through tissue, regardless of what kind of tissue it is. The other thing is that sound is going to move in a straight line. So look at this little thing right here. So the transducer, which is sitting up here, is going to send a sound beam out and wait for that echo to come back. It'll send a sound beam, wait for that echo to come back, and it took X amount of time for that to come back. So it's going to assume that there is something that is echogenic that's giving back a reflection there. When you have the interface between something fluid-filled, like the liver over here, right next to something that's air-filled, like the lung, that creates an extremely reflective surface for sound. Everything actually bounces off of it. So what'll happen, another little sound beam will come off of the transducer, it'll hit the diaphragm, bounce off it, hit that echogenic thing, come back to the diaphragm, and then come all the way back up to the transducer. And because the ultrasound machine thinks that everything moves in a straight line, it thinks that there must be something down there. And so that's how a mirror sign is created. A mirror sign is a mirror of what's below the diaphragm, above the diaphragm, and you only see this when you have air in the thorax, which means the absence of a pleural effusion. So if you see a mirror sign, you do not have a pleural effusion. Does that make sense?
Nope, you lost me.
Mirror sign means no pleural effusion.
Got it.
All right, sweet. So let's move on to my favorite one, which is the spine sign. Now, you might not have paid attention to this in the past, but look at these little arches right here. What do you think these are, Matt?
It's still the spine sign, so I'm going to guess it's either a spine or a sign.
That's good. So these are actually the spine shadows. So this is the lumbar and low thoracic vertebral bodies. And remember, we talked about this being the diaphragm up here. And what's weird is you notice that spine, it looks like it disappears. Does the patient still have a spine?
Poof. It's gone.
It's gone. Does the patient still have a spine, though?
I bet they do.
Yeah, but if the ultrasound machine can't see it, the ultrasound machine doesn't know it exists. And remember, sound reflects back sound waves.
Whoa. Now, I agreed to sit back and let you guys talk about this lung BS for several podcasts, but now you've gone too far. Sound reflects sound? Really? That's some perpetual motion BS. I think you mean air interface reflects sound, or maybe a significant change in impedance reflects sound, or maybe you mean that an effusion transmits the sound waves through the fluid and then some of them bounce off the bone of the spine. Maybe that's what you meant. I'm pretty sure you didn't mean sound reflects sound. Come on, man, did you even proofread this?
So if the ultrasound machine can't make it to the thoracic vertebral bodies, the ultrasound machine doesn't know they exist and it disappears. So this is what it looks like when you don't have a pleural effusion. You have the lack of a spine sign, or you don't have the spine extending past that diaphragm there. So here's an example. I want you to look at this. You see this little guy right here? This is a spine here. Here's another one right here.
Yep.
And what you see as I hit play, you see how actually as the diaphragm moves down, it gets rid of one of those spines because the air is being brought a little more inferiorly. And as the air comes down inferiorly, it actually stops that sound wave from getting to that spine and makes it disappear. This is a negative spine sign. This is the absence of a pleural effusion.
Yeah, I think I see a mirror sign too there. You can see those hepatic veins maybe.
Definitely. So if you look at the ecotexture below the diaphragm here and above the diaphragm here, you can see that they're the same. So this patient has a positive mirror sign and a negative spine sign, which indicates no pleural effusion. Now I want you to contrast that with this image right here. What do you see here, Matt?
I can see the spine going above the diaphragm.
And why is that?
I guess the ultrasound beams have something they can travel through, like
That's right.
fluid or
Exactly.
consolidated lung. In this case, looks like black stuff, so I'm guessing fluid.
Yeah, and you actually bring up a good point here. Consolidated lung, like in pneumonia, can also cause a positive mirror sign, but you want to look for that hypoechoic or anechoic fluid for the pleural effusion. And a pneumonia will look a little bit differently, and I'll show you that in a couple of slides. Now, I want you to look at this right here, and this is the reason why I like the spine sign so much. I'm not a huge fan of the mirror sign. Do you think this is a positive or a negative mirror sign, Matt?
I do not see... Well, I mean, the ecotexture looks similar, but I see the spine.
Right, so let's ignore the spine. If you ignore the spine, would you be able to say if that's a negative mirror sign or a positive mirror sign? What would you say?
It looks pretty similar. I mean, maybe it looks a little darker, but it looks pretty similar.
I agree. Now, and that's the thing, is that if you have debris in your fluid, like a bad hemothorax or a bad pyothorax, like an empyema, you might actually not be able to use that mirror sign because the texture of that exudate might actually be pretty similar to the texture of the livers. But in this case, you can see that spine extending across. There's something transmitting sound to the thoracic vertebral bodies, and in this case, it was a hemothorax in a patient.
So while we're talking about pleural effusions, is there a way to differentiate transudate from exudate on ultrasound? I get that question a lot.
That's a really good question.
And my next question is, what does this tapioca pudding with bubbles in it have to do with pleural effusions?
That is one of my favorite things I did in residency. I took this out of a 16-year-old male's chest. Isn't that amazing? That's
tapioca
just
pudding in the chest?
I don't know how it got there.
Wow.
I don't know how it got there. It looked like a little bit like pea soup to me.
Delicious.
All right, so yeah, sometimes you can. Now, if you see something like this, some people call this the plankton sign. See all this like debris in there, all this echogenic little debris in here. You see that kind of moving around?
Yeah.
That is very likely to be an exudate of effusion. So if you see stuff in there, it's likely to be exudate. But if you see something like this, it could be transudate, it could be exudate. You can't really tell. So if you see the plankton sign, it's exudate. If you don't see the plankton sign, it can be transudate or exudate.
And what is that lung nest monster on the left?
That is the lung, actually.
Oh, makes sense.
All right. And another thing that I don't know if you knew about, Matt, but you can actually measure out that pleural effusion and estimate the size. There are two ways you can do that. You can do that by using the Remeran formula or the Balick formula. Do you want to do the more complicated one or the less complicated one first?
Oh, I'm going to say neither. But I feel like you're going to make me do these. Okay.
Yes, we're going to do this. We're going to do this because it's actually pretty easy. So there's two different ways. The Remeran formula actually calculates the volume just based off of the length in an area, and the Balick formula is a little easier because it takes less steps. Let's talk about the Balick formula first. So the first thing you're going to do is identify that pleural effusion. So you've identified that pleural effusion, and then you're going to stick that thing in the transverse orientation like this, and you need to find the biggest pocket of fluid you can find. After you found that biggest pocket of fluid, you go ahead and measure that and you multiply that number in millimeters by 20 and it estimates the size. You see how easy that is? I mean, it's you get one number and multiply it by 20. It's pretty easy. This is the one that honestly I typically use just because it takes less steps. But if you have a little more time and you want to be a little more accurate, you should probably learn the Remeran method. Now, the Remeran method essentially takes the volume of that pleural effusion. So here, imagine this cylinder is the lung and this is that pleural effusion. It measures the area of that pleural effusion with the height of that pleural effusion to get the volume. So the way that you're going to do this, and this is from the journal article that describes it, is you find the upper limit of the pleural effusion, you find the lower limit of that pleural effusion, and then you measure that length, and then you find that mid length. So you need to find the most superior portion, the most inferior portion, actually measure that out, figure out how long that is, and then find that midpoint. After you found that midpoint, what you're going to actually do is you're going to actually go over here and measure out the air. Matt, did you just fall asleep?
Sorry, just wake me up when this is over. No, wait. Actually, tell me. I think I heard something already. You said, so which one do I use if I don't have time and I don't care?
The Balak formula.
Great.
All right, let me just finish with...
I'm just going to erase that from my memory as well. Just let me know when you're done with this.
All right, I'll let you know when I'm done. Measure out the length here, times that area, and find the volume. Pretty impressive looking pleural effusion there, don't you say, Matt?
I agree.
So basically, you'll get this and you'll just trace it. So you just bring that cursor, trace it all the way around, multiply that by the length, and then you got your formula. Now, these actually do pretty good. The Balak formula was found to correlate at 0.72, or have a 0.72 correlation. The Rembrandt method, if you use the thoracentesis, was 0.84. The CT scan was 0.9. So these are actually fairly accurate ways of diagnosing it.
Now, sorry about the falling asleep thing, but
It's okay. I forgive you.
I want to know if there's an effusion, and I want to know, is it big enough that I need to drain it? And I do that by looking at it and looking at my patient. Are they
Agreed.
sick enough that it needs to be drained? Why would I ever need to know this number?
So the reason why is if you're an intensivist or you're up on the wards, knowing exactly how much fluid might actually be helpful to your practice to know exactly the amount instead of going to get that CT scan. Some people might actually need to know this information. And granted, in the ER, we usually don't need to know exactly the amount. We just say, is it small, is it medium, or is it large? Do I think that this is causing the actual patient symptoms? I mean, that's definitely the most
I
important
thought
thing.
you were just teaching this to me right now. Is this recording?
This is recording. Yeah, we are recording this for the
wow.
Ultrasound Podcast.
Okay. All right, then.
All right, so let's move on and talk about how to actually diagnose pneumonia. Now, with pneumonia, I usually actually start in the right dependent portion, so the lowest portion of the lung, because statistically speaking, that is the most likely place for pneumonia to be present because there's just more lung tissue there. And you can have the patient sitting up. Sitting up is probably a little bit better because you can make sure to evaluate this posterior area of the thorax here. And what I often do is I'll have the patient actually lift their arm and place it kind of on their head. And what you see here is you can see that when they do that, their scapula actually rotates a little bit and gets a little bit out of the way. And that might give you a rib space or two extra. And if you get that rib space or two extra, you're going to be more accurate because you're going to be able to evaluate more of the lung.
Jacob, so with this incredible sensitivity and everything, it seems like we should be doing this a lot, but I don't want our listeners to feel bad for not doing this because, I mean, this is a brand new thing, right? This just came out in the literature.
No, it's actually been around for a while. This study actually describes it perfectly. Came out in 1986. And look at these images here. These are exactly how we find pneumonia now. So this has been around for a long time, and I'm not sure why we don't all do it.
1986. That's incredible. So, all right. So tell me exactly how, like what signs do we look for? How do we do this?
All right. So there are a couple of different signs that you can use. It's air bronchograms, B lines, pleural effusion, subpleural consolidations, fluid bronchograms, and pleural line abnormalities. Now, air bronchograms and fluid bronchograms are pretty specific for pneumonia, but the rest of these can actually be present in other things. And this kind of goes along with what I've been saying, and that is that you can't use ultrasound in a vacuum. You can't use it by itself. You have to use everything, including your history and physical exam, to figure out what's going on with your patient. So pleural effusions, obviously they can be seen in other things besides a pneumonia. They can be seen in malignancy, CHF, tuberculosis, cirrhosis, pulmonary embolism, B lines. I talked about this before. We can see it in CHF, pulmonary contusions, ARDS, interstitial lung disease, atelectasis. Subpleural consolidations, which are some of my favorite things to find, can be seen in pulmonary embolism, septic embolism, pulmonary contusions, and ARDS. And pleural line abnormalities can be seen in ARDS, malignancy, and interstitial lung disease. So let's talk about air bronchograms, which is probably the most specific way to diagnose pneumonia. You have static air bronchograms and dynamic air bronchograms. Now, the dynamic air bronchograms are seen only in pneumonia, but the static air bronchograms can actually be seen in pneumonia and atelectasis. So remember this image that we saw before, Matt, that same fast exam image? And remember, I wanted you to focus in on this pleural line and look at what's above that pleural line. So remember, this is a mirror sign. This is a negative spine sign. This patient does not have any consolidation, has no pleural effusion. And I want you to think about seeing this instead. What do you make of this?
See the spine sign. So there's something there. There's not dark and black like a pleural effusion.
Talking about up here?
Yeah, above the diaphragm.
Yeah, so this is actually a static air bronchogram. And the first time I heard static air bronchogram, I was a little bit confused because, I mean, these are moving, right? I mean, these aren't completely static, but they move with the lung. So they're static in relation to the lung. Here's another example of a static air bronchogram. You can see the liver over here, and over here you can see all of these little hyperechoic punctate lesions, which are static air bronchograms. You can see that spine sign down here.
Okay, now you got a good picture of the liver. What's the point?
So yeah, this definitely looks a lot like the liver. You maybe have the liver here. This would be the diaphragm. This would be the kidney should be, right? But I'm going to go ahead and hit play on this, and I want you to tell me what you see. What was that? What were those?
Worms, lung worms.
Those were lung worms or pneumonia worms. Those were dynamic air bronchograms, and they're right here, and right here. And what dynamic air bronchograms are thought to represent are air that is stuck within the bronchi that have obstruction in them. So the air can't effectively move all the way to the end of their pathway. They're stuck within a certain segment, and that's thought to be very specific for pneumonia. So imagine you're looking at the anterior or lateral chest wall. You have good lung sliding here, maybe an A line down here. And what if instead of that, you see something like this? Now, we are above the diaphragm here. This is definitely not the liver. This is definitely not the spleen. This is a huge consolidation. And these over here, these are all air bronchograms within a massive consolidation. That's pretty bad pneumonia here.
So you're saying static or dynamic bronchograms can be seen in a pneumonia?
Correct. Now, the difference is that the dynamic air bronchograms, this little wormy thing that you see over here, the dynamic air bronchogram is thought to pretty much only happen in pneumonia, and a static air bronchogram can actually happen in really bad atelectasis. So, if you have a static air bronchogram, unconsolidated lung without dynamic air bronchograms, it could be that it's just really bad atelectasis. So you have to kind of see if the patient has signs and symptoms of pneumonia. Do they have a physical exam consistent with a pneumonia? And if they have that with a static air bronchogram, you can diagnose that as a pneumonia. But if they have been on the ventilator for 2 days or laying down flat and they haven't really been able to expand their lungs, there's a chance that those findings could be atelectasis.
But dynamic is definitely pneumonia, you're saying?
Correct.
Now, you said it's thought that that's true. Are there actually any studies? Because I've actually tried to look this up and haven't really found anything.
No, unfortunately, there are no studies that look at this for every pneumonia, but this has really never been described in any other situation besides an actual pneumonia. So it's not 100% perfect, but we haven't actually found any other situation where dynamic air bronchograms are present besides pneumonia. So have you ever seen a retrocardiac pneumonia?
Yes.
Have you seen it like just now, or have you seen it before this?
It's not something I see all the time, but...
Okay, so here you have the left side of the heart, and here you see consolidation with the static air bronchograms. This is retrocardiac pneumonia, and here's another example of retrocardiac pneumonia. See that heart beating right there? See that consolidation right behind it? This is a pneumonia.
And the cool thing about this is something that normally we're talking about in the context of something commonly missed on X-ray.
Yeah, exactly. This is definitely often missed on X-ray, but if you do an ultrasound and you look behind the heart, you won't miss it. So this is another finding you will see. This is a subpleural consolidation. Do you see this little wedge of hypoechoic fluid right there? You see that? This is a subpleural consolidation. This is another way that pneumonia has been described. Here's another one right here, maybe a little more subtle. See that pleural line is really raggedy, and see that triangular shape right here? This patient, if they have a cough and a fever, they have pneumonia. Here's another example right here. It's much more subtle, but what you see here is this subpleural consolidation with these B lines. You see these B lines over here? Usually, if you see this subpleural consolidation just by itself, it might be something else, but if you see a subpleural consolidation with B lines surrounding it, it implies surrounding inflammation, and this surrounding inflammation would make it more indicative of pneumonia. Now, there is one other sign here, and it is a fluid bronchogram. You see that fluid bronchogram right there, Matt?
I'll be honest, I don't really see what you're talking about. Oh, there you go.
I circled it for you. You see this little thing right over there? So this is thought to be the progression of an air bronchogram. So once that little bronchus becomes completely fluid-filled, it will turn into a fluid bronchogram. And basically what you're seeing fluid inside a bronchus. One thing that this could be is a blood vessel. So some people have actually talked about throwing some color flow on to see if it's a blood vessel or not. But to me, that doesn't really matter. Because if the lung is so consolidated that you're actually able to see blood vessels within the lung, and differentiating between blood vessels and fluid bronchograms isn't really important. If their lung is so consolidated that you're actually able to see blood vessels, they probably have pneumonia. And this is a patient with a complicated peripneumonic effusion. So you got a big pneumonia right here, and you see these little fibrin strands right here. These would make you be more concerned for a complicated peripneumonic effusion. And here is basically a chest that is forming an empyema. Here's a lung and here's a liver, and you see these little fibrin strands right here? This is concerning for an empyema. This is just a nasty lung right here. Look how disgusting it looks. You see all that pus in there? Now, this slide is basically here so you can take a screenshot of it. This is how often specific pneumonia findings are reported to be present in the literature. And it kind of varies, but the most common findings are going to be air bronchograms and subpleural consolidations.
Tweetable.
Often when I give these lectures, I get asked about two other signs. I get asked about the shred sign and hepatization. Hepatization is something that basically we already talked about. It's when the lungs get so consolidated. So here's the lung over here. It gets so consolidated that it looks just like the liver. I think that's an okay word to use, but I think we've already called it a consolidation with dynamic air bronchograms, and I like calling things based off of what they are. And this is a consolidation with dynamic air bronchograms and static air bronchograms. The other thing is a shred sign. The shred sign is basically the border of the consolidation. So it's kind of this stuff over here. So I don't think it's as useful to describe as a sign, but I'm still okay with it. It's just another way to describe the border of a pneumonia. So to recap, pleural effusions. You want to look for the spine sign and the mirror sign. If the mirror sign extends past the diaphragm, then there's something transmitting sound to the thoracic vertebral bodies. A mirror sign is when you have a very similar or identical echo texture above as you have below the diaphragm. If you don't have the mirror sign, it means that you have a pleural effusion. If you have a mirror sign, it means you don't have a pleural effusion. And for pneumonia, the most common signs are going to be bronchograms. There are a few different types of bronchograms. You can see dynamic or static air bronchograms and or fluid bronchograms. The other kind of specific finding for pneumonia are subpleural consolidation. Now, there are a bunch of other ways that pneumonia has been described, but these other signs are probably less specific for pneumonia. And when we see these softer signs, we don't necessarily need to treat all of them. I mean, one of the things I'm hopefully going to talk about in the future is at what point, if you identify what you think is pneumonia on ultrasound, you should actually treat. So we'll talk about that in the next couple of podcasts, but know that in the literature, it has been described as being present when you have B lines, when you have small subpleural consolidations, or when you have those air bronchograms.
Jacob, great stuff. I look forward to the conversation with Vicky. Now, tell the people out there where they could hear more from you and learn more from you.
Yeah, so this stuff is kind of a lot, and kind of like drinking from a fire hose. I have this website, I don't know if you've heard of it, it's called 5minutessauna.com, and basically it's a collection of short videos that show you how to do particular ultrasound exams. They're usually around 5 minutes, but to be honest, some of them are a bit longer than 5 minutes. In these videos, I don't talk about the literature behind them or the evidence for doing them, I just show you how to do it. So this is for that time that you're about to walk into a patient's room and you're like, I want to remember how to do that posterior tibial nerve block, but I don't have time to read an article on it. I don't have time to watch a long video. You can watch one of mine. If you have any questions or comments, you can always send me an email or tweet.
And how much is probably like $99 a month subscription to 5 Minute Sono or something like that?
This is 100% free. This is free open access medical education. So the total cost comes out to free $99.
If you're not good enough at ultrasound, that's not an excuse to punish your patients with radiation.
Get out there, ultrasound some hearts, some lungs, some IVCs. Let us know how you feel about it.
Yeah, we can definitely do that, or we could be better clinicians and use our ultrasound.
They know that I need the right electricity to move my disco feet. They know that I need a rhythm of ecstasy to get the disco feel. Baby, give me the song that keeps rolling all night long until the break of dawn. Baby, give me the one, 'cause we like to get it done before tomorrow comes. So don't turn back, 'cause we can feel the funky groove. Baby, don't distract, lose contact, 'cause we believe you got the moves. And baby, you seem to wonder why we drive in disco light. You know I don't, you know I won't get it down. You seem to wonder how my funky vicious love. You know I don't, you know I won't fail you. Shoes on my feet, move to the pounding beat, unstoppable indeed. Looks irisy, tell me just what you need, a dancing disco dream. Baby, give all you got, 'cause this isn't good enough, can't take no fake or bluff. Baby, give me the one, 'cause we like to get it done before tomorrow comes.
Hey, honey, how do I make my forehead not super shiny?
Do you want to put some makeup on it?
Is it kind of like lotion on it?
Huh?
It's like super shiny.
I hope this is recording.
Lotion will make it more shiny. I'll put a little powder.
I'm really glad I tested ScreenFlow right at that moment.